Hey everyone, and welcome. Today we're diving into a really essential explainer created just for you, the educators. We're going to look at how to equip you with a fully standardized, super effective framework for transitioning Phase 3 undergraduate students safely into their clinical rotations. Because let's be honest, that leap from the classroom to the actual clinical environment, it's massive. And exactly how we manage that transition fundamentally shapes the kind of clinicians these students are going to become.
So here is our roadmap for today. First up, standardizing safe clinical training. Second, Peyton's 4-step approach. Third, the suturing DO checklist. And finally, we'll wrap up with the feedback sandwich. Basically, we're breaking this down into a pedagogical triad: the method, the measurement, and the aftermath, just to make sure learning is as structured and effective as possible.
All right, part 1. Standardizing safe clinical training to ensure student competence. As educators, our shared responsibility is to create an environment of safe, structured, and consistent training for literally every single student entering the wards. We just can't leave skill acquisition up to chance, right? We need a solid baseline.
There's a quote from the source material that hits the nail on the head. Standardization ensures safe and competent students. It perfectly captures our foundational thesis. It's a great reminder that the habits we build in the controlled, safe environment of the simulation lab directly dictate the safety of the operating room later down the line. If our teaching is standardized, our student safety protocols will be too.
Let's move right into Section 2, Peyton's 4-step approach, which is really the engine of the lesson. This is our first pillar, and it builds a rock-solid foundation for teaching clinical skills.
Picture your simulation lab. How do you actually transfer a really complex psychomotor skill? Well, step 1 is demonstration. The trainer just performs the basic suturing silently at normal speed. This gives the student a real-time mental model of what fluid competence actually looks like. Then, step 2, deconstruction. The trainer repeats it, but this time breaks it down, explaining every single step out loud. Step 3 is comprehension, and honestly, this is where the magic happens. The cognitive load shifts entirely. The student now has to verbally instruct the trainer on exactly what to do. Finally, step 4, performance. The student actually takes the instruments and does the procedure themselves while the trainer observes.
Now, during those middle phases, deconstruction and comprehension, it is absolutely vital to explicitly cover the specific technical requirements. We're not just talking about pushing a needle through skin here. It's a whole process. It starts way before you touch the patient, with getting informed consent and preparing instruments. Then it's about maintaining aseptic technique, handling tissue gently, and getting that perfect 90-degree needle entry, which, is usually the very first thing students forget when the pressure's on. You also need a secure square knot, proper spacing, and you even have to get the finish right, cutting the suture tail to approximately 5 millimeters and safely disposing of your sharps.
So, once the student actually grabs the instruments during the performance phase, we're faced with a critical question. How do we objectively measure their performance? We taught them the standard, sure, but how do we evaluate them fairly so every trainer is using the exact same scale?
That brings us to Section 3, the suturing DO checklist, which serves as our lens of assessment. This is the objective tool that focuses our evaluation purely on safety, precision, and technique.
Just take a look at the simplicity of this rubric. You'll be using this exact layout to evaluate students in real time. It's just 4 simple columns. You've got the step number, the specific action, a straightforward check, cross, or not applicable, and a spot for remarks. This binary approach, like did they do it or did they not, completely removes the subjectivity, and it maps perfectly one-to-one with the 10 steps we just deconstructed. But here is the absolutely crucial takeaway. You have to pay very close attention to the 5 asterisk steps on that checklist. These are our critical safety markers: obtaining informed consent, strict aseptic technique, 90-degree needle entry, tying a secure square knot, and safely disposing of sharps. These aren't just minor stylistic preferences, they're fatal flaws. If a student misses even one of these, they are directly compromising patient safety or the safety of the whole clinical team.
All right, Section 4, the feedback sandwich, your fuel for improvement. The performance is done, the sharps are in the bin, the checklist is filled out. Now we hit the final pillar of our triad, delivering constructive critique. Because, let's face it, evaluation is pretty useless if we don't communicate it effectively.
A great way to structure that conversation is the classic feedback sandwich. It's highly reliable for adult learning. You start with a positive, really reinforce what they nailed, like maybe their aseptic technique was totally flawless. Then you discuss an improvement. Maybe that needle entry wasn't exactly 90 degrees. And you wrap it up with an actionable goal for their next practice session. This builds up their clinical competence without completely crushing their confidence. As we wrap up this explainer, I want you to ask yourself, are we standardizing our simulation labs to truly guarantee safety in tomorrow's operating rooms? Are you applying this triad, Peyton's approach, the DOE checklist, and the feedback sandwich, consistently? The work we put into the simulation lab today is the only way we guarantee our Phase 3 students become genuinely safe, competent clinicians. Think about how you're going to integrate these tools into your very next teaching session. You've got this.